Okay, here we are at our second cardiovascular topic. So here we're going to talk about heart failure. In terms of underpinning, what we'll look at is systolic versus diastolic heart failure. We'll also look a little bit at the compensation and decompensation mechanisms. That will then lead us into the applied pathophysiology, which really depends on whether it's left-sided or right-sided. And we'll talk about the concepts of forward failure and backward failure. So overall, heart failure is the inability of the heart to produce adequate cardiac output to meet the perfusion and oxygenation requirements of the body's tissues. So in a way, it's a bit like our atherosclerosis, but in this case, we don't have an occluded vessel. What we have is a defective pump, if you like, pumping it out in the first place. And we can categorize it in terms of being systolic or diastolic. And they both have differences in terms of the structural changes of the myocardium. In systolic heart failure, what we get is a thin, weakened myocardium. We get reduced contractile function because we don't have that muscle mass. Because of that, we get an increase in end systolic volume. Remember that contractility is about pushing out the blood, leaving as little as possible inside the ventricle. If you can't push it out, if you can't contract hard enough, then you will have more left in the ventricle. In other words, increased end systolic volume. If you have increased end systolic volume, of course, you have a reduced stroke volume. Remember, stroke volume is end diastolic volume minus end systolic volume, which is logical. It's the amount that's gone out, the difference between the two. So we have decreased stroke volume, decreased cardiac output, because stroke volume is a key part of cardiac output, and we will have decreased blood pressure because cardiac output is a factor of blood pressure. In diastolic heart failure, we have a bit of the opposite happening. We have a thicker myocardium, but it's stiff. So we're going to have a smaller chamber, a thicker myocardium, a myocardium that can't stretch as well, but also can't relax as well. So in this case, what we have is a reduced end diastolic volume. Because we've got a smaller chamber, that end diastolic volume, there's less room for it, so it's going to be decreased. If you reduce end diastolic volume, of course, you also decrease stroke volume, cardiac output, and blood pressure. Ejection fraction is a factor that we haven't really talked about before. What it is, it's stroke volume as a percentage of end diastolic volume. In a healthy adult, it's about 50 to 75%. In systolic failure, there is a reduced ejection fraction, so 40% or less, because stroke volume is reduced by increased end systolic volume. So stroke volume is down, but EDV is staying more or less the same. So we have a bigger difference. So this may be expressed, the heart failure in this systolic situation of systolic failure may be called HF, R, EF. In other words, heart failure reduced ejection fraction. In diastolic failure, ejection fraction is preserved because EDV is also reduced. Both stroke volume and EDV are reduced. So we're not actually reducing the difference between the two. So this, in diastolic failure, may be expressed as HF, heart failure, preserved P ejection fraction. So we get HF, PEF. So if you see HF, REF, it's talking about systolic failure. If you see HF, PEF, we're talking about diastolic failure. Our potential causes in terms of systolic heart failure, acute myocardial infarction, because that's impairing contractility. So we are going to have a higher end systolic volume. Another cause is dilated cardiomyopathy. In dilated cardiomyopathy, classically what you see is a thin, weak myocardium, just like systolic heart failure. And this is caused in its own right by genetic disorders, by chronic hypertension, viral infections, valve dysfunctions, alcoholism, or even pregnancy. Diastolic failure is generally caused by an increased afterload. If you remember, afterload is the pressure that the contractility is trying to push against. And common causes of that were hypertension. So we've got the back pressure of all the blood at a high pressure, or aortic stenosis, where you get a valve that's not very willing to open. It's like pushing a sticky door. This increased afterload will eventually cause myocardial hypertrophy. The cardiomyocytes will have to increase to get more strength to push against this afterload. Another cause of diastolic heart failure, a little rarer, is constrictive pericarditis. This sometimes happens following infection, or even rarer, in amyloidosis. This is a condition where you get a build-up of these proteins, these specific proteins in the tissues. It is quite rare. So that was the difference between systolic and diastolic. The next thing we're going to talk about is compensation and decompensation. In many situations where the body has a failing system, it will try and compensate. And we know from physiology, if we've got low cardiac output and low blood pressure, we have two compensatory mechanisms. There's the baroreceptor reflex, which activates the sympathetic nervous system, and we have RAS, a bit slower, but eventually RAS will kick in. So in terms of compensation for the baroreceptor reflex, what happens is that low cardiac output, low blood pressure is detected by the baroreceptors in the aortic arch of the carotids. They then activate the sympathetic nervous system. Sympathetic nervous system, as we know, I would hope by now, increases heart rate, so that's the chronotropic compensation, and increases contractility, the strength of contraction of the myocardium. This is our inotropic compensation to raise cardiac output. That's all great, but the problem is if you overstimulate something, so we've got all this noradrenaline floating around from our sympathetic efferents, binding to beta-1 adrenoreceptors in both those mechanisms, the myocytes themselves will feel a little, under pressure, a little overstimulated. So what they will do is they will downregulate the beta-1 adrenoreceptors. In other words, they won't express as many on their plasma membranes. They will take them in. They will endocytose them, get rid of them. We're getting overstimulated here. We don't need all these beta-1 adrenoreceptors. It's too much pressure. We're going to take some away. Of course, when they do that, the problem is you can produce all the noradrenaline you like in the world. If there's no adrenoreceptors for it to bind to, then it's not going to be very effective. So this is decompensation. In relation to RAS, we know about RAS. This kicks in a bit slower, but we have low cardiac output, low BP. That's then detected in the glomerulus by the juxtaglomerular apparatus. That detects, pressure's down. Hang on, I'll secrete some renin. And off we go. We end up with angiotensin II, we end up with aldosterone, ADH, and what we do is we reabsorb more water, that bulks out the blood, we get increased blood volume, that increases preload. If we increase preload, remember Frank Starling, we increase the stretch. If we increase the stretch, we increase the recoil, the contraction. This isn't, remember, our contractility. This is the contraction as a result of stretch. That all increases end-diastolic volume, stroke volume, cardiac output, and blood pressure. Lovely. That's great. But all this increased stretch and contraction requires adequate myocyte perfusion, but it also causes the myocytes to start to get bigger. They hypertrophy because they've got all this extra work to do. It's a bit like you doing some bodybuilding, lifting some weights. Your muscles get bigger. So we get myocyte hypertrophy, which requires even more perfusion. If that perfusion is not adequate for these hypertrophied myocytes, so remember this could be where we get our thickened myocardium, they may go into apoptosis. They become stressed. Remember we talked about apoptosis in the last video. So the death receptors get activated, or the intrinsic mechanisms get activated due to mitochondrial stress, and they go into apoptosis because they don't have enough perfusion. If they go into apoptosis, of course, we're going to end up with a weak myocardium. Our cardiomyocytes are dying off, and that's decompensation. Which brings us on to another way of categorizing heart failure. And this will really lead into our signs and symptoms because it has an impact on what we see. Heart failure can be categorized as right-sided or left-sided. The heart has a left side and a right side. Both right and left-sided can occur as a result of systolic or diastolic heart failure. Both result in reduced cardiac output, but for different reasons. And with different effects depending on where cardiac output is reduced to. So think about left versus right side. Think about our two circulations. We have a pulmonary circulation, we have a systemic circulation. On the right side of the heart, the inflow, the venous return, is from the systemic circulation. We have the superior and the inferior vena cava empty into the atria, etc., etc. The outflow is to the pulmonary circulation via the pulmonary artery, because this is blood that's coming back from the body. It needs to go off to the lungs to get oxygenated. On the left side, the inflow is that blood coming back from the lungs. The venous return is from the pulmonary circulation via the pulmonary vein. So the blood's been off, it's got oxygenated, comes back into the left side for outflow to the systemic circulation. So outflow, our cardiac output here, is to the systemic circulation via the aorta. And this has a massive impact on the signs that we see. It always also gives us this concept of backward and forward failure. So, forward and backward failure. Forward failure is all about reduced cardiac output. Reduced cardiac output, of course, it is going to result in reduced tissue and organ perfusion. Backward failure is caused by this problem of moving the blood through. If you can't move the blood through and out of the heart into cardiac output, you're going to get back pressure. You're going to get a build-up behind, a bit like a roadblock. If you can't get the cars through the roadblock, the cars build up and you get a tailback. In terms of blood, that gives you increased hydrostatic pressure in the vessels. When you get increased hydrostatic pressure, you've got all this blood rammed in these vessels. They get engorged, they stretch, but they also leak. And what they leak, of course, is going to be fluid, protein-light fluid, transudation, a fluid out of the circulation. And these two mechanisms in terms of left and right give us the signs and symptoms of heart failure. Well, that brings us nicely into our applied pathophysiology. So we're talking signs and symptoms. In terms of right-sided, we have some different signs and symptoms, but at the top on both, notice we have fatigue for both, although they might be slightly different mechanisms. Okay, so right-sided forward failure. Remember, this concept forward failure is in terms of our cardiac output, and backward failure is in terms of venous return to a particular side of the heart. So this point, we're talking about right side. So think where the right side cardiac output is going to. It's going to the pulmonary circulation. So fatigue in this case could be down to a reduced perfusion of the capillaries within the lungs. If we reduce that, it is going to have an impact on gaseous exchange. So we're going to have reduced oxygenation because there's reduced perfusion and reduced removal of CO2. So reduced respiratory function is going to cause fatigue in terms of the tissues throughout the body because we've got reduced gaseous exchange, reduced oxygen, we've got increased CO2. As the pulmonary circulation, of course, once it gets through the lungs, it eventually, all a bit tired now, returns to the left ventricle. Because that is going to be slightly reduced, the left end diastolic volume and cardiac output to the systemic circulation will also be reduced. In addition to this, of course, the sympathetic nervous system is going to cause peripheral vasoconstriction. And we talked about this before in atherosclerosis in terms of pallor, because the skin is not so well perfused, but also the muscles in the periphery are not going to be so well perfused. So there is the potential for weakness in the limbs because of peripheral vasoconstriction. Right-sided backward failure. So, okay, if we think about the right side and where it's backing up to, it's backing up into the vena cava. So we have the potential for raised JVP, jugular venous pressure. Because blood is not being moved through the heart, the superior vena cava, in this case in terms of JVP, becomes engorged. This then backlogs to the jugular vein, particularly the internal one, which is where you look for JVP. This is your jugular venous pressure in the internal jugular vein. If you've got back pressure there, you're going to start to see engorgement of that internal jugular vein, and it's going to give you raised JVP. In the same way, this backward failure is going to have an impact in terms of the inferior vena cava. Of course, the next organ down is the liver. So we have hepatomegaly, but we also tend to get splenomegaly because we've got this systemic congestion of blood within the capillary beds of organs. Those beds, those capillary beds in the organs are very fine. So you start to get a bit of congestion within those. This increases the hydrostatic pressure in those capillary beds. Because they're very fine, they also tend to be a little bit leaky too. So we have the potential for transudation of fluid into the organs. This is a bit like our pulmonary edema in terms of the pulmonary circulation, but here we're talking about the systemic organs, the abdominal organs. Eventually, this transudation from these capillary beds leaks into the peritoneal cavity. If it leaks in at a rate that is beyond the ability of the lymphatic system to drain away, you will start to get a buildup of fluid in the peritoneal cavity. And we know this as ascites. In terms of the tissues, this translates really into edema. Again, we have this systemic increased hydrostatic pressure, all this blood trying to return to the heart. It's not getting pumped through. It's back pressure. This is our backward failure. We're getting increased hydrostatic pressure and transudation throughout the systemic system. In terms of edema, in the periphery, of course, we get transudation. And then gravity causes it to pool. And it tends to pool, of course, because most of the time we're sitting or standing. It tends to pool in the ankles. So gravity causes this transudation to pool in the ankles. Because this is transudate we're talking about here, not exudate, it's low protein content. Because of this, it gives us this phenomenon of pitting, where if you press it, it doesn't immediately bounce back because we're just moving fluid around. It takes a while to move back. Weight gain is due to this overall fluid retention. At night, that fluid that's all lying around in the tissues moves back into the circulation because we're lying down now, so there's no more gravity, it's not a problem, body's nice and supine. All this fluid can move back into the circulation. When it does that, of course, what it's going to do is increase glomerular filtration rate. All this blood with all this fluid is going to hit the glomerulus, and through pressure natriuresis, remember that, it's going to move into the renal tubules, go down the collection duct, and we're going to wake up needing to go for a wee. So left side then, left side forward failure. Think about the left side, think about where that blood's going. It's going into the aorta, and then it's going round the systemic circulation. So in terms of fatigue, we do have the obvious there. We have reduced systemic cardiac output. That means the tissues are not going to be as well perfused. They're not going to get as much oxygen. They're not going to be able to make as much ATP. So they're going to be a bit weak and weary. In addition to that, we'll talk about this in a minute, we have backward failure. Backward failure in left-sided heart failure causes pulmonary edema. Pulmonary edema fills the alveoli with fluid, reduces gaseous exchange. So not only are we getting less blood out, but we've not done a very good job at removing the carbon dioxide and putting some oxygen in. In addition to that, there may be some sleep disturbance. And this sleep disturbance, again, we'll talk about this in a while, we have this situation where we have Cheyne-Stokes breathing happening at night. That Cheyne-Stokes type breathing wakes people up, so they don't sleep as well. In addition, the sympathetic nervous system, our old friend, will also cause peripheral vasoconstriction, reducing perfusion to the limbs, resulting in weakness. So we've got multiple causes of fatigue here. There is reduced urinary output. If you think about this, we've got low cardiac output, systemic cardiac output. That gets round to the glomerulus. Oh, hang on, low cardiac output, low blood pressure. That activates RAS via the juxtaglomerular apparatus. We end up with angiotensin II, aldosterone, ADH. They all increase water reabsorption in the renal tubules. Great, that increases our preload and all the rest of it. But what it also does, it reduces the output. Not much is going to get down to the bladder. Palpitations, again, we talked about those in terms of atherosclerosis. We have the sympathetic nervous system activated. So we're going to get chronotropic and inotropic upregulation. So left-sided backward failure then. We think about the left side. Where's the blood coming from? Yes, it's coming from the pulmonary circulation. So pulmonary edema is quite key in left-sided heart failure. It's a key aspect of it. And this is why left-sided is often called congestive cardiac failure. Blood is not being pumped effectively, so we get this backlog into the pulmonary veins, into the capillaries around the alveoli. Here we have increased hydrostatic pressure. As a result of that, we have transudation into the interstitial space and into the alveoli. As a result of this, we may have dyspnea, tachypnea, gaseous exchange is reduced. That's going to stimulate the peripheral and central chemoreceptors. They're going to increase respiratory rate. In addition, remember our J receptors. Capillary engorgement and interstitial fluid are the two things that stimulate the J receptors. And if you remember, the J receptors give this perception of dyspnea, or are thought to. Cough. We've got all this fluid floating around. Not only have we got fluid, you've got increased respiration, increased rate, increased effort. That causes shear force in terms of the air moving in and out of the airways. Shear force and fluid activate the mechanical cough receptors. These mechanical cough receptors are known as rapidly adapting receptors, RAS. And we'll talk more about those when we talk about respiratory. Pink-tinged sputum is down to erythrocytes. Transudate leaks into the alveoli, sometimes with it a few erythrocytes sneak through, get into the alveoli, get into the sputum, and tinge it pink. Orthopnea, again, this is about gravity and fluid. When you're sitting up or standing, the fluid in the alveoli is going to tend to affect the bases more because of gravity. Soon as the patient lies down, that fluid disperses throughout all the alveoli. So we have more J receptors activated. We have gaseous exchange reduced in more alveoli. So this increases not only the sensation, but also the physiological difficulty in breathing. It increases it in more of the lung parenchyma than when standing up. Paroxysmal dyspnea is quite complex. So I've tried to simplify it in terms of what happens in terms of sleep apnea. Generally in heart failure patients, because they're breathing faster, the PCO2 levels tend to be a little bit lower. It doesn't have to be much lower, just a little bit lower. At night, that's one of the things that can trigger sleep apnea. So they're more prone to sleep apnea. So we've got low PCO2. We don't need to breathe. We don't need to get rid of CO2. We can stop breathing. So in heart failure patients with these lower PCO2 levels, they are more prone to sleep apnea. After sleep apnea, of course, the levels get so bad that there is a period of compensatory hyperventilation. There is a reaction to that when the chemoreceptors become activated. So you get these cycles of apnea and hyperventilation. This can present as a Cheyne-Stokes type pattern of respiration overnight. Well, that brings us to the end of heart failure, our second cardiovascular topic. There is no more. I can't overload you too much, but of course there is lots more to know. But meanwhile, access the handout if you want a text version of the video. Make your own notes and diagrams. And remember, keep learning the material every single week, just like you did in physiology. Otherwise, it's all going to be a massive job at the end. If you still haven't found your study buddy, try and sort that out this week. And, as always, if you find you're a bit hazy on your physiology, please go back and revise it so that this all makes perfect sense. And again, as we said, plenty more to learn.